Hello dear viewers, through this video I am going to start this series on continuous renal or the kidney replacement therapies in ICU. This is part 1 of this series where initially I will be discussing an overview of renal replacement therapies and then continuous therapy. I am Dr. Sunil Garg from Essentials of Acute Care. The management of patients with acute kidney injury is supportive, with kidney replacement therapy indicated in patients with severe kidney injury. Multiple modalities of kidney replacement therapies are available. These include intermittent hemodialysis, continuous kidney replacement therapy or CRRT, and hybrid therapy, also known as prolonged intermittent kidney replacement therapy, such as sustained low efficiency dialysis and extended duration dialysis. Accepted urgent indications for kidney replacement therapy in patients with acute kidney injury generally include fluid overload refractory to diuretic therapy. Severe hyperkalemia means when the plasma potassium concentration is more than 6.5 or rapidly rising potassium level. Overt manifestations of uremia such as pericarditis, encephalopathy, or an otherwise unexplained decline in mental status. Severe metabolic acidosis means when the pH is less than 7.1 despite medical management. Though the benefit of KRT in patients with lactic acidosis is uncertain, and certain alcohol and drug intoxications amenable to extracorporeal therapy. Now I will discuss only continuous form of renal replacement therapy. Continuous renal replacement therapy or CRRT is commonly used renal replacement therapy in ICU setting. Based on clinical practice patterns, the major indication for choosing CKRT over intermittent hemodialysis is hemodynamic instability. Hypotension is widely believed to be less common with CKRT because the rates of fluid and solute removal are slower than with intermittent hemodialysis. CKRT is particularly beneficial for hemodynamically unstable patients who require ongoing large volume fluid management such as multiple intravenous medications or total parenteral nutrition. Because CKRT is a continuous therapy, the net solute removal over 48 hours is higher than with intermittent hemodialysis despite the lower rate of solute removal with CRRT. CKRT is also preferable over intermittent hemodialysis for patients with acute brain injury or other causes of increased intracranial pressure who have AKI. This is because intermittent hemodialysis is more likely to worsen cerebral edema via a decrease in the mean arterial pressure, which causes compensatory cerebral vasodilation, and via a rapid removal of urea, resulting in a shift of water to the intracellular space. Other special conditions where CKRT may be preferred include sepsis, burns, heart failure, and liver failure. CKRT may be more practical for treating certain drug toxicities where the agent is dialyzable but slowly transport to the plasma water compartment. Intermittent hemodialysis rather than CKRT may be better for the treatment of patients with severe hyperkalemia means when there is presence of ECG changes such as worsening peak T waves or QRS prolongation that are refractory to calcium supplementation even if the patient requires vasopressor during the treatment. Even with using the highest effluent rate possible with the CKRT, bulk potassium removal with standard treatment hemodialysis or prolonged intermittent kidney replacement therapy is much more efficient on a mint-to-mint basis. This requires clinical judgment and often depends on multiple other variables including the availability of dialysis nursing staff. No specific CKRT modality has been shown to provide better outcomes. In most cases, the choice of CKRT modality within individual institution depends on equipment and staff availability, expertise of the clinicians. In some settings, the technique depends on the degree to which solute and/or fluid must be removed, means what is the patient's need. For example, slow continuous ultrafiltration is used exclusively to remove fluid but is not useful for patients who require solute removal. There are mainly four types of CRRT modalities which I will discuss here, that is CVVH, CVVHD, CVVHD-F and SCUF or SCUF. Continuous veno-venous hemofiltration or CVVH uses hydrostatic pressure to induce the filtration of plasma water across the hemofilter membrane. Solutes are removed entirely by convection. In this modality, dialysate fluid is not used. The ultrafiltration rate is high and in the range of 20 to 25 ml per kg per hour. As a result, replacement fluid must be given to prevent volume depletion. The amount of replacement fluid that is given is determined by the net volume removal that is desired in the patient. Small and middle molecular weight molecules means less than 5000 Dalton such as urea and electrolytes are removed in roughly the same concentration as plasma water. There is therefore no change in the plasma concentration of these solute by hemofiltration. However, the administration of a substitution fluid lowers the plasma concentration of solute such as urea and creatinine by dilution that are not present in the substitution fluid. There is no change in the plasma electrolyte concentration as replacement fluid contains electrolyte. Continuous veno-venous hemodialysis or CVVHD primarily removes solute by diffusion. Hence, dialysate fluid is used. As in intermittent hemodialysis, dialysate fluid is run countercurrent to the direction of blood flow at a rate of 1 to 2 liters per hour or 20 to 25 ml per kg per hour. By contrast to CVVH, the ultrafiltration rate is generally only 2 to 8 ml per minute. In CVVHD, the ultrafiltration is limited to the rate at which net fluid removal is desired in the patient, and in this modality, no intravenous fluid replacement is required. CVVHDF or continuous veno-venous hemodiafiltration combines diffusion with convection. It requires infusion of both replacement fluid and dialysis fluid. Similar to CVVH, the ultrafiltration volume is variable and replacement fluid must be given to maintain euvolemia. The amount of replacement fluid that is given is determined by the net volume removal that is desired in the patient. Slow continuous ultrafiltration is used to treat isolated fluid overload conditions. It is not useful in patients who are uremic or hyperkalemic because in SCUF solute removal is minimal. It can safely remove up to 8 liters of fluid per day. Neither replacement fluid nor dialysate fluid is used. In this modality, convective solute loss is limited since the ultrafiltration rate is low compared with the CVVH. There is no diffusive solute loss since dialysate fluid is not used. The blood flow is generally 100 to 200 ml per minute and the ultrafiltration rate 2 to 8 ml per minute. So to summarize, the choice of renal replacement therapy depends on availability of staff and equipment, physician experience, indication of renal replacement therapy, underlying disease condition, and most importantly, hemodynamic status of the patient. In terms of the modality of continuous renal replacement therapy, it depends on availability of replacement fluids, clinical experience, and preference of physician and patient need means solute removal is required, fluid removal is required, or both. Here I finish. If you have any feedback, suggestions or comments, please write them down in the comment section. See you in my next video, which will be part 2 of CRRT. Till then, bye and take care.